Hello everyone, this is your host Kevin McCardle. Thank you very much for joining us and welcome to this program on revenue cycle management strategies for navigating the changing reimbursement landscape. For this program, I'll be joined by Erika Running, the Vice President of Analytics here at Sisu, and Erika will be sharing some high-level strategies, some best practices, and some practical tools to help you get the results that you deserve from your organization, from your business. And I do want you to know that today's webinar is being recorded and will be made available following the program. And also, Megan O'Leary, our Director of Marketing, is available to field questions from you. So I would encourage you to submit any questions that you have, and Erika and I will do our best to answer those questions during the webinar. You can just use the question box in the GoToWebinar menu over on the right side of the screen. And I do want you to know in the time that we have together, Erika's going to be giving you lots of content-rich material. And at the end of the session, I'll let you know how you can have greater access to more information on the topic. So with that, let's get to work. Erika, welcome, and help us think of some insights on how we need to be thinking about this topic of revenue cycle management.
Thanks, Kevin. It's great to be here today, and I want to welcome everyone to the webinar. This is a topic that I'm very passionate about, so I'm happy to spread my knowledge and expertise and hopefully get you guys thinking and maybe help you create some new teams or some new structure within your organization to help you with some revenue cycle management strategies. So today, we're just going to kind of hop into it. We have lots to talk about today. There is quite a bit that we're going to cover. The first thing we're going to talk about is we're going to take a look at our history of Medicare reimbursement. I truly feel that if you want to predict the future, you really need to look at the past, and we're going to take a look at that today. We're going to talk about MACRA. MACRA is the new the Medicare Access and CHIP Reauthorization Act of 2015. It repealed, or the sustainable growth rate was repealed, and MACRA is going to take over. So we're going to talk about what we know today, including some of the new items that CMS recently released as late as last week. And then we're going to look at the overall solution. And this is where I start to get really excited, because there are 4 elements of the revenue cycle that I sort of take an approach with to applying a more holistic revenue cycle management solution. And within each category, I want to talk to you about different things that you can do today, things that you should be thinking about so that you can have a very successful facility and a very healthy financial bottom line. So taking a look at our history, our beloved Teddy Roosevelt said, "The more you know about the past, the better prepared you are for the future." And I cannot agree with him more. Medicare has gone through some significant transformation since 1965, all leading up to this, which is our future. Within the next 10 years, we have consistent, constant change happening in the reimbursement landscape. We are going from a pure numbers and pure volume reimbursement format to a value-based reimbursement format where consumers like you and I can log on to the CMS website and look at our hospitals and see how they're rated, and also see how our physicians are rated, so that we can shop around and we can pick the best possible physician for our services that we need. So in the next 10 years, every single year, there's going to be some sort of increase or decrease in payment, whether you fall into the MIPS category or the APM category as a qualified provider. Something is going to have to change. Things are changing, and they're changing very rapidly. But to understand the change, we have to remember in 1965, Medicare was born. 1966, CPT codes were developed. So we've come a long way. Then in 73, our Medicare benefits were expanded, and in 82, the inpatient prospective payment system was implemented. That was really the first major reimbursement change that we saw with Medicare, was the development of the inpatient prospective payment system. But that's definitely not the last. In 84, HCPCS were developed and introduced. In 88, we started using ICD-9, if anyone can remember ICD-9, since ICD-10 is now the new buzzword. In 89, this is where revenue cycle management really comes into play, where Medicare claim submission, in an electronic format anyway, is required. This is where technology and the information age really came into play. And revenue cycle became a huge player in that arena. In 91, E&M codes were created. In 92, the resource-based relative value scale was created. This would be the second major reimbursement change or structure from Medicare that we would see, creating the RVU-based system. In 2000, then we had another big change with the outpatient prospective payment system being implemented. Then 9 years later, ARA and the HITECH Act were passed. This is really the dawn of, and the beginning of meaningful use, as well as value-based reimbursement. 2010, the PPACA was passed, and just this year, we have the sustainable growth rate being repealed and MACRA introduced. MACRA in itself is a very, very disruptive law. It basically takes what we know today and turns it incredibly upside down into a 180 spin, and it sends our entire clinical departments and our revenue cycle departments into a tailspin, because in 2017 we have to prepare for this very disruptive law. So there's two things that I'm going to be showing you today. The first is sort of a short-term tactical strategy, and the second thing is a long-term strategic roadmap. Now, just last week, we were given notice by CMS that physicians and facilities would have basically 4 options to comply with MACRA. But the one thing I want to say about CMS's release is that there's no real delay in this. They're just giving you some options and basically kind of a go at your own pace compliancy with the law. No matter what, the sustainable growth rate was repealed, and MACRA is coming. Whether you begin to comply in late 2016 into early 2017, or you choose one of CMS's other options to comply with the law, it is coming. And it is incredibly complex. If you've gone out and you've just briefly looked at the new law, you'll see that there's 4 categories, cost and resource use and quality, and they're all kind of related back to PQRS and meaningful use. They use some of the same core measures, but ultimately the calculation to get to the final score for the qualified physician or the qualified provider is very complicated. There's a lot that goes into it, and it requires a lot of effort both from the clinical world and the financial world. It's definitely an area that we have not seen before, where we are definitely bringing our clinical practice more into the revenue cycle than we have. It should have been one tightly knit group to begin with, but truly CMS is pushing us into this holistic revenue cycle management approach. So for MACRA, we have some short-term to-dos within the law. So you can choose to do it now, or you can choose to do it in 2017. Either way, these are some of the things that you're going to have to do. You're going to want to take what you're doing today with PQRS and meaningful use and kind of align that with a MACRA work plan. When you take a look at MACRA, there are 2 categories. There's MIPS and there's APMs. And MIPS is the Medicare Merit-Based Incentive Payment Program, and APMs are the advanced payment models. We want to take a look at the core measures that both of those programs are looking to track, and you want to take a look at what you're doing today for PQRS and meaningful use, because ultimately those 2 items are going to be sunsetted because MACRA is coming into play. So you don't want to reinvent the wheel, but you do want to align the 2. In any system, I can definitely tell you there are activities and things that you can do to optimize and improve your performance. We have customers here at Sisu that we are constantly working with on a daily basis to help them optimize their systems. I'm going to talk a little bit about technology later, but I can't stress to you enough how facilities underutilize the power of their EHR technology system. It is the absolute backbone and the spine of the facility, and there's always areas to improve and optimize. We also want to try and look at performance management tools, either by individual provider or by an entire group or tax ID number. Within MACRA, physicians have to choose, or facilities have to choose, whether you report by individual physicians or as a group. And there are pros and cons to each, but whichever way you choose, there's definitely, your lower performing physicians have opportunities to improve, and we want to take a look at that. So in the next quarter, the next 3 months, your 2017 MACRA roadmap kind of looks like this. Like I said, you want to align everything, you want to optimize, and you want to improve your performance by provider. Towards the end of the year, maybe early next year, if you're a MIPS provider, so you got to really take a look at your providers and really understand, because it truly all relates back to billing. Where are these providers billing from? And this will determine your category, whether you're MIPS or you're an APM. To do a MIPS implementation, because if you think back to that timeline that I showed you earlier from CMS, MIPS is the first category that we're going to start reporting. So we need to develop an implementation plan to finalize all the workflows, the different measures that each physician chooses, whether they're in a specialty. You might want to choose just the specialty workflows and measures for them. Start to track their performance and make sure that they're compliant. There needs to be a lot of education. I truly believe that CMS has underestimated how much physicians have been in touch with what's going on with MACRA. At least the facilities and the folks that I've talked to so far, there's been a lot of big question marks above their heads. They have not either heard of it or don't understand it. So compliance with MACRA is going to be a struggle, I believe. Then comes the reporting and the tracking. So for 2016 at least, and maybe even into 2017, we don't really have a clear direction yet, but in 2016, PQRS measures are still going to be appropriate. We're still going to have to report PQRS. We're still going to have to complete our 2016 meaningful use attestations. But in addition to all of that, we now need to add on our MIPS monthly performance, because ultimately, PQRS and meaningful use will be sunsetted, and MIPS will be the new measure that we'll be tracking. Now, MIPS, at least in the first year, if you submit any data at all, basically to CMS, this is kind of what they've outlined. As long as you're submitting something to them, you're not going to get a payment reduction. But you still need to track your performance, because ultimately in the future, that's going to determine your payment, either adjustment in the positive or in the negative. It's also going to determine the quality rate for that physician, whether or not they're a 1-star provider or a 5-star provider. Whatever that looks like, you need to have visibility right away into their performance.
Erika, excuse me.
Yeah.
We have a question from Tracy in Nebraska.
Okay.
And Tracy was wondering, what is the best way to stay on top of the MACRA changes as they get closer? She's probably referring to the recent announcement. You know what? So how could Tracy and her colleagues and our listeners and our participants, how do they stay abreast of the changes as they get closer and as they're rolled out and announced?
So some of the tools that I use are sort of email listservs that I subscribe to. Obviously, CMS is a great source, but sometimes they're a little slow to release a lot of detail, or they release a lot of detail, and it's just not real user understandable. So I subscribe to Fierce Health IT. I also subscribe to Becker's Hospital Review. Let's see, this one is from healthcareinformatics.com. There's many outlets that will provide you information. I find that Fierce Health IT is a great one. HIF Talk is another great resource that I use. So just going out to their website, you can subscribe to different categories of information. It's a free service. You know, you can get a daily sort of journal from each website, or you can subscribe to the latest breaking news and you'll get it real time. Because MACRA to me is such a complicated law and that there's still a lot of uncertainties around it, I subscribe to the latest breaking information, so I'm constantly staying on top of those things. In addition, I would also talk to your EHR vendor because they should be on top of this as well, because it plays a big part into technology. So they may have some resources for you as well.
Those are great resources. Thank you, Erika.
So looking at a long-term strategy for MACRA, we have MIPS reporting and monitoring that we're going to have to do in 2017. And whether you do it by provider or you do it by the entire group, it's completely up to you. You know, data is key. You might want to try both because your performance is going to be based on your lowest performing provider. So you want to kind of see who that is in the organization and maybe help them along to improve their performance. In 2017, we're also going to be introducing alternative payment models. And you're going to really have to sit down with the law and take a look at whether or not your facility it applies to the APM model. APMs are not as widely talked about right now just because APMs, their effective dates aren't as quickly as the MIPS reporting and requirements. But for facilities who are more complicated in their billing practices, maybe you are a Medicare demonstration program, maybe you're a certified medical home, critical access method 2 facility, you're going to want to take a look at the APM models because those are the types of facilities that would fall into the APMs. So if you are one of those, you want to develop some sort of steering committee to take a look at your current practices today because you're going to need to develop some sort of work plan to work towards APMs. And in the APMs, basically, you're kind of excluded from the MIPS reporting categories, but there are different items that you would have to report on in order to get the bonus payment from CMS, which we all would want. And some providers are actually dual MIPS and APMs, so take a look at those. But truly, to do all of those activities, to take a look at your providers, to take a look at your technology, to develop these steering committees, I go back to my comment that I made about MACRA, in that MACRA and your position within MACRA is completely dependent upon how you're doing your billing today and what your billing status is. So this really introduces the revenue cycle into our clinical practice, and it really integrates it very holistically. So today, because revenue cycle is definitely my passion, I want to talk to you about my suggestions or the solutions that I have around a more holistic revenue cycle management strategy. So I made this word cloud because I just talked to you at length about MACRA and the changes we're facing in 2017 with MACRA and how we're going from a quantity-based reimbursement system to a value-based reimbursement management system. But today, I know many of my facilities that I work with in this word cloud are dealing with at least half, if not all, of these items that are on this list. You know, we're dealing with PQRS. We're still in the ICD-10 conversion. We're trying to submit more things electronically. We're and monitoring our HCAP scores. We have meaningful use. We're doing CDM audits, training, trying to develop clinical documentation improvement activities. I mean, there are so many things within the revenue cycle that we're trying to tackle today that are already taking up our time. Now we have to introduce MACRA into this mix. And so we need to take a more broader look and see how we can take MACRA and weave it into all of the things that we're working with today so that the revenue cycle in its environment is successful. So when I talk about the revenue cycle, most everyone thinks that the revenue cycle is just about the business office. And I cannot stress enough that the revenue cycle is not about the business office. The business office is just that. It's an office. The revenue cycle is in totality all the different spots the patients could visit within their service. So whether I'm at registration, or I'm seeing a provider, or the caseworker is working on a discharge plan for me, or the phlebotomist that is taking my blood, or the nutritionist that is coming to talk to me about my diabetes, every single one of those spots, every single point in that visit is part of the revenue cycle. And Edward Martinez, who is a very forward-thinking man, said the work has shifted just from heads-down tracking bills to allowing a more strategic thinking about how we refine our processes and make them even better. And I want to point out that the one key word in that quote is the strategic word. The revenue cycle has to be strategic, and it has to be something that we work with all of our departments together to come up with a solution. Because as you look at this graphic, billing and collecting, you see number 5 there in the green, that's just one little component in a large circle of departments. We have staff from every single department of the hospital touching this patient, which impacts our reimbursement and our revenue. So it is not about tracking the bills. It is not about just collecting. It is about taking care of the patient from a holistic approach in all of these departments. And if you're not doing it today, then you need to start doing it tomorrow. And I'm going to give you some pointers on how to do that. So here's what it's not. We just talked about this. I'm not an automaton, looking at Medicare. I'm not just working in my little business office. I'm not just talking to my coworkers. I'm not just trying to push 1,000 claims through the system. And I'm not reactive, meaning I'm not going to sit back and wait for somebody to tell me what to do. Because what we are in the business office is automated, we're integrated, we're clinically driven, we're patient-focused, and we're very proactive. And learning about MACRA is the first thing that you can do to be very proactive to begin with in a more holistic revenue cycle approach. So we have, like I talked about, there are 4 areas in which I want to sort of introduce you to. The first in the revenue cycle management approach is people. So we obviously need humans to do the job. We need humans to control technology, and we want to put these humans doing the right work at the right time. Secondly is the process. So the patient has to go from point A to point B to point C to point D and all the way through the process. But how much of that are we still trying to babysit, and how much of that is still in a paper system when we have purchased these multi-million-dollar EHR systems that we're not harnessing the power of? The third is our technology. So like I said, we have these multi-million-dollar EHR systems, and they're built and maintained by skilled staff who understand integration, but are we really using them to their best and biggest capability? And the last thing is data. This is where my position here at Sisu really comes into play. As the VP of Analytics, I'm really pushed and driven to identify areas of the financial health of the facility. You really can't make any decisions without understanding where you are today. So data really helps us with strategic decisions, also clinical discovery, and our overall financial health. So the first item in revenue cycle management is people. So think about everyone that you have working with you today, whether you're in the business office or in registration or in coding or in nursing, whatever position you're in today, think about the people that are currently in your department, and also think of the folks in departments that you may work with closely. Thinking about that, I bet you can, every single one of us could identify that there are 4 generations in the workplace. That's unheard of. And I'm sure you've heard about this in other management seminars and webinars, but 4 generations in the workplace is incredibly difficult to manage. Not everyone has the same management style. I like to be more flexible, whereas my my baby boomer generation counterparts, they may like more structure. But whatever it is, every generation agrees that being flexible with your hours will allow your staff to be more productive. This is just one area that we at Sisu have learned quite well because we're a technology company. We're able to let our folks work flexible hours when it works for them. So if it works for me to work from 8 to 5, great. But if it works for me to work from 10 to 6, fine. It's being more flexible with your hours, being flexible with your management style, really listening to your employees, and making sure that they can be productive when it fits their schedule. And luckily, or I should say I'm proud, that Sisu, just this year in 2016, we were awarded the When Work Works Award, which basically is an award for Sisu to recognize our flexibility in our workplace. I kind of like to think of us as the Google of Minnesota, because we're kind of that cutting edge, really cool, neat company that just allows their staff to kind of come and go as they please, but it's incredible how much more our folks get done in that time period. In addition to your flexible schedules, we have to look at our hiring practices and our management process. So as a manager, as somebody who has to inspire and work with employees to kind of be the best version of their professional selves as possible, the biggest thing that I recognize and encourage people to do is cross-training. Number one, it helps you with depth in your department, whether you're in a business office and you have a Medicare biller and a Blue Cross biller and a Medicaid biller, or you're in coding and you have an inpatient and an outpatient coder, whatever it may be, cross-train those people so that if one person is on vacation or maternity leave or has an unfortunate accident, or I like to say win the lottery, that you have coverage. So it creates coverage, but it also encourages career development, because for the 4 generations to learn from each other, they need to train from each other. I need to understand why my baby boomer counterpart is so into the structure and so into the why, or not really the why, but just getting the work done, or maybe as the Generation Xer, I'm asking the why questions. Well, why does it work that way? Why do you do it that way? And you can really learn from each other. Both generations can really take a lot from that experience. As hard as it can be to manage 4 generations, we still have to customize our management styles. Communication is probably the biggest issue and hurdle for any manager. How people communicate with each other can range from email to face-to-face meetings to text messages to instant messaging to Facebook Messenger to you name it. There's multiple ways to communicate. So learn how your folks like communication. And I like to tell this story because my boss here at Sisu, she's the CIO, brilliant woman, worked for a large organization before Sisu, and is older than I am. I would have expected that email would have been her preferred communication style with me. So when I first started at Sisu, I would send emails to her, giving her updates on things or asking questions. And it turns out that she gets so many emails in a day that she never got to reading mine until about a week later. So to remedy that, I know that she always carries her phone, so my communication style with her is text message. She always will get my questions and my updates and my information via text message. and that's just our preferred method of communication. It's not always the greatest because it's nonverbal, and as we all know, nonverbal communication can be some of the worst communication because you can't see their face. But it is one of those items where if I need a quick response, a text message is the way to go for us. So rethink your communication styles and your management styles because you can go a long way with your employees. This is where it gets a little uncomfortable for people in this next bullet, is having the right people in the right seats. So we want to make sure that we leverage the strengths of our employees rather than trying to retrain our employees to do something they're not programmed to do. So, for example, internally here we have a big project going on, and we have staff in different positions, either as analysts or report writers or things like that. And one of our employees showed incredible interest in becoming a SQL reporter. It's a position that we hadn't really talked about creating or hiring for. We have a couple people in-house that do it, but this person really showed an interest for it. And once we decided to make the move to switch him into SQL reporting, the amount of productivity that this person produced was exponential. It was amazing. And the best thing is that this employee absolutely loves what he's doing now. So what do? We just backfill what he was doing before. We have somebody who is incredibly productive, who loves the work, who is doing self-training and self-certifications, and really we couldn't ask for anything better. Somebody who is totally motivated to do the job. So I challenge you to think about the people that are in your seats today. Do they love what they're doing? Are they good at it? Can they think outside the box? Can they solve problems? Truly, truly, truly rethink the right people in the right seats. And lastly, we want to take the people we have today, find your thought leaders. The people today in the business office or in coding or wherever you are, those people who are keeping up on the changes within Medicare, who are truly taking a look at your systems and maybe trying to develop new workflows and make things more automated, these are your thought leaders. And you want to take them and you want to hone their skills. Send them to education sessions, send them for cross-training, whatever it may be, but hone their skills because these are your future executives. So the second component of this, so we talked about people, now we're going to talk about process. So within any process, you can't manage it unless it's measured, right? So if I'm talking about the process of collecting copays in the ER, or just collecting copays in general, I don't know what I don't know. So everything within a process needs to be measured. So we need to turn data into information and information into insight. So again, we're talking about our revenue cycle, which is going to include our EHR technology, it's going to include data, and it's going to require people to run the data. So ask yourself a question. Do you have people within your organization that can get you the data that you need to manage a process? And if you do, then you're challenged with process improvement. And process improvement never ends. It's continual. It's all the time. Because we have changes from Medicare coming down and CMS and Medicaid and Blue Cross and the exchanges and ANSI codes. I mean, everything is changing. We are constantly changing our revenue cycle. It's constantly transforming. So you need some sort of methodology to apply to those changes. And whether you choose Lean Six Sigma, which is a big popular one, or business process modeling, or Stimulate, or Mind Tools, I don't care which one you choose. Just choose one that's user-friendly for you and easy to follow, and stick to it. This is the biggest hurdle that I see facilities choose is one department might use Lean Six Sigma, but another department might use business process modeling. They all come to the same conclusion at some point, but if your departments are not speaking the same language with the same process improvement tools, you're never going to get anywhere. So as a facility, as an organization, choose one and go with that one. Also, with process, we need to use data and analytics to make decisions, to understand where we need to focus our efforts. Because if you don't know where the bottlenecks are, you can't fix them. And you can use different types of data to measure these. The biggest, most popular one, I guess you could call it, would be your key performance indicators. I myself am a big fan of HFMA's MAP keys. I apply them in my daily work with my customers because they are vetted formulas, nationally recognized, that the finance management group in the United States sort of subscribe to. But Lean Six Sigma also has some tools that you can use to measure productivity. And we also have time trials. So whether you're trying to measure patient throughput, time trials might be a tool or a key component of data that you want to use. You can use all three of these if you like, but you have to use something in order to measure the process, because you're never going to understand where your bottlenecks are unless you're measuring your outcomes.
Erika, we have another question.
Sure.
And I think this one is related both to process and people. It's from Andrew in Kansas. And Andrew wrote in, his question said, would you recommend designating someone in our facility exclusively to manage our revenue cycle and monitor analytics, in addition to the revenue cycle committee? So it sounds like they might have a revenue cycle committee in place, but I think what Andrew's asking is a champion that is their sole role and their exclusive role to do the process improvement, manage analytics. What's your perspective and insight on that?
I kind of feel like there's maybe a hybrid approach you could take to that. The Revenue Cycle Management Committee is key. It is crucial to the success of the organization. Having players from all the different clinical departments and financial departments present at the table to talk about issues. But truly, in any organization, change typically comes from the top down. So a business office director or a patient financial services director can only go so far without the approval and without the championship of the CFO or the CEO or the CIO, whoever that may be at the C-level. I truly believe that the C-level would be the key player to kind of manage and choose which issue or process or strategy you're going to attack first, to kind of give direction. And then the business office director, maybe in conjunction with an HIM director or patient access director, would maybe manage the analytics along with IT. So you really got to kind of marry them all. I don't believe that a one-person approach to managing this is the right way to go, because then you're single-threaded.
Sure.
There's no depth. You really need to share the knowledge and understand the knowledge, and every person has a perspective about the data, and you need to understand it. But developing those data and developing the reports really is a combination of the business office talking to IT and trying to come to a conclusion on what is the right data coming out of the system, and the CFO or the CEO, whatever C-level you want to choose, is the one to champion the change and really enforce the change across all departments.
Okay.
So
that's a clear distinction. I'm sure Andrew's going to find, and the rest of our participants are going to find that insight helpful. It was surprised me. It wasn't the answer I expected, but I think your answer was very insightful, and I think it makes a lot more sense than my original perspective on that. So nicely done. I think that's good input.
Good. Well, thank you. That's actually a great segue into number 3, because number 3, we're going to talk about the data. So data will talk if you're willing to listen to it, according to Jim Bergson. And I, again, can't agree with him more, because when you sit down and you take a look at your organization, and if somebody presents to you gorgeous, pretty pie charts or graph charts of your days in AI, your DNFB, or DNFC, you're going to be able to see where things are lying. So again, we have these 3 types of data that you can use: KPIs from HFMA, or you can make your own KPIs. If you determine that there's a key performance indicator that you're wanting to track, start to track it. The key is you need to begin pulling the data out of your system. And again, I challenge you, does your organization have the right tools, the right reports, the right people to track this information? And if you don't, you need to get it. Because it's not always easy to get. And we can definitely, at Sisu here, attest to that, because it requires very, very skilled staff with not only knowledge of their EHR system, but also revenue cycle management to pull this information out of the system. Here at Sisu, I'm working on key performance indicators for our facilities, and I'm learning that our members or our facilities are pulling reports and information that maybe don't directly translate or correlate to the HFMA map keys. And I have to demonstrate why they're different and why the reports that we're pulling here at Sisu are a better fit or a better match for those map keys. And a lot of eyeballs are being widened because we're showing them that maybe the data you were pulling in the past worked, but over time, with system changes or upgrades or process changes, we have to adapt to those changes. So again, I want to challenge you. Do you have the right people with both the revenue cycle management knowledge and the knowledge of their EHR system, the core guts of how it was built and how it functions to get to this data? One thing that I see folks do a lot is they take a whole bunch of data out of their system, they put it on a bunch of spreadsheets, and they create some pivot tables, and they create some graphs, and it's meaningless. And it's meaningless is because it's way too much. You're trying to measure, and you're trying to do too much at one time. For an organization to really manage their data, you really need to break it into small pieces. So don't take a huge topic like throughput in the ER. That is ginormous. That is huge. You really need to take it and break it into small pieces and do it in small elements, like starting with the number of ER visits by time. So if I look at ER visits by time, you can understand your busiest hours, and maybe you can hone in on those times and begin looking at throughput just as those times. So you're really taking a ginormous category of data, narrowing it down to just a small section of time, and then you're just looking at that subsection of patients, which is a lot more manageable than just one giant report of 100,000 lines. So taking data and making it into something more manageable that you can actually analyze, and it'll start to tell a story. So that if it's really busy at 2 p.m., you can start looking at types of patients. Are they Medicare patients? Are they Medicaid patients? Are they Blue Cross patients? Are they going to be admitted? Are they going into surgery? Or are they just urgent care type visits? This will allow you to make better business decisions on what types of services that you offer in your facilities as well. So you always have to mix data and people together because you can't get the data without a person controlling the computer. So we know that our IT staff are generally very, very, very busy people. These folks are being called upon quite a bit to manage upgrades, to manage servers, to work with physicians on challenges that they may face, issues in a department, whatever it may be. So we're left with very few hours in the work week to work with our IT staff. So then you need to start looking internally at your own departments. Do you have folks in your departments that are super user level that may be able to critically think about the data? So I would challenge you, maybe you have these folks in your department. And if you do, these are again your thought leaders. You need to pull them out, start to really hone those skills, start to work with them. Maybe they just need a little bit more education. Maybe they could benefit from cross-training with IT. Whatever it may be, you need to start building these people up because then you don't have a huge reliance on IT. Maybe you have a partial reliance on IT. IT is a very critical and crucial department to our hospitals nowadays with EHRs. So we need to develop more of these skills within our own staff. And again, these super users should be critically trained so that they can analyze the data to tell you the story. Because it takes a lot of time to pull this data out of the system, to boil it down to something that's more usable, and then really tell the story. Why is something happening? Where can I pinpoint the bottleneck, or where is the issue? Are we having reimbursement issues with Medicaid? Whatever it may be, these people need to be trained on how to tell the story. Lastly, we're going to talk about technology. Technology in the last few years has really come a long way. I mean, if you think about that Medicare timeline, in 1989 was the first time Medicare required us to submit items electronically. And that's only, what, 25 years, 26 years, 26 years ago? I mean, it sounds like a lifetime, and it kind of is, but truly, within the last 26 years, we have totally changed the way we do business. And we can't do any sort of analytics without technology, but you can't have analytics without resources and talent in this category. So, like I said, if you don't have anyone that's a super user, and if you're not getting the help, or IT is so focused on other projects, which is very common, you're going to have to go out and buy them and pay for them. And I'm not talking about a system or a new EHR system or a new third-party vendor. I'm talking about go contract the talent to go get you this information. Because some of the common mistakes I see with EHR systems, number one, when you implement a new EHR or you're upgrading an EHR, whatever you're doing, everyone does it in the vanilla version. And they always say, oh, that's phase 2. Oh, that enhancement, that's going to come phase 2. And guess what? You never, ever, ever do phase 2, do you? Because every single facility I've worked with, at least in my career, the reason why I was brought in was because they never did phase 2. That portion of the technology was never implemented. Secondly, it's like they implement and you forget. So you implement the system and it runs great for a few years, but none of the information has changed. Unless you're a very high-performing facility, I see a lot of facilities not updating either their live environment or their test environment or both. And the one in particular that is very common in my line of business is if you're posting payer remittances electronically, those payers are sending back ANSI standard remittance codes. And typically, for a system to accept those remittance codes, they have to be built somewhere in the system so that they recognize those codes. Well, a common mistake is that facilities forget that those codes are updated twice a year. And for the last 5 years, maybe they've been posting these codes in the system and everything looks great, but they have not kept up their list in their system. So not updating your EHR system is a detriment to you. You need to spend time with your system and getting the most current information in there. Third is that every facility thinks that their current EHR system can't do what they want to do, and they're so wrong. In particular, we have EHR systems that are incredibly smart and productive, and they can do amazing things. But again, I go back to number one, and that you installed the vanilla version. You didn't install the cool and the latest and greatest functionality. And what happens is, because they install the vanilla version and they don't realize that the system can do lots of things and bells and whistles that you've already paid for, they go out and they buy third-party add-ons to do those bells and whistles that they want to do without investigating their EHR. And I challenge you to think about your current third-party systems and think to yourself, do you think my system could do that today? Is there a possibility that my system could do denial management? Can it do contract management? Can it do, registry reporting? There's many, many third-party systems out there that revenue cycle management companies capitalize on. And I would challenge you to try and bring some of those things back in-house because your systems that you've already paid for are very powerful. So some best practices within your EHR. Number one, keep it updated as often as you possibly can. Review your setup because your dictionaries, your master files, your patient indexes, whatever you want to call them, are the backbone of your facility. They need to be updated. If a user leaves the department, deactivate that user right away and any other places where that person may appear. Same thing if you add a new insurance. You may add the new insurance, but you add it to all the other workflows. You add it to your coding workflow, to your patient access workflow. You need to really rethink of where you're updating your information. And lastly, please do not ever try and replicate a process from your old EHR to your new EHR. They are not the same, and they are not the same because they're competitors. So do not try and take what you're doing in the old system and do it in the new system because it won't work. Take a look at the functionality in your new system, harness that functionality, and yes, you're going to have to change your processes, but that's okay because most of the time it results in time savings. Sometimes it results in decreased days in AR. Sometimes it results in a better patient satisfaction experience. Whatever it results in, just don't do it because square pegs and round holes don't work. At least that's what my dad said. So, wrapping up, I have a few thoughts. Number one, the SGR, the sustainable growth rate, was repealed. So whether you like it or not, MACRA is coming, and it's coming maybe in a staged approach, but it's on its way. Meaningful use is still not going away. We still have to attest to stage 3, or at least that's where we're headed, and we still need to work and strive towards that. MACRA is going to tie our clinical and financial workflows in a way we've never experienced before. And then lastly, I want you to ask yourself another question. I've asked you to ask yourself many questions today, but if you were to apply all 4 areas of the revenue cycle management strategy, the people, the process, the data, and the technology, would you say that you're ready for the skull-crushing complexity that is MACRA? Because I know in many facilities the answer would be no. So a few things that you need to do. Hopefully this presentation allows you to sort of rethink your revenue cycle a little bit. Maybe working within your departments, start to take a more holistic, patient-centered approach because I guarantee you'll be successful. So some action steps. If you don't already have a revenue cycle committee, I'd like you to form one and really think about your key players and making sure that not just finance is at the table, but you've got some really great clinical key players. You're going to be amazed at their perspective on the revenue cycle. And it's going to be your opportunity to educate and promote financial stability within your organization. IT is going to be a huge player in your revenue cycle. They are going to help you generate the data and the KPIs and any information that you need to make a decision. And lastly, because today is all about preparing for that value-based reimbursement landscape, I want you to take a look and form a MACRA work committee because, like I said, it's coming. Whether you like it or not, you're going to have to determine what your short-term strategies and your long-term goals are going to be when it comes to implementing MACRA. And hopefully you take some of these revenue cycle management principles, weave them in to that work committee so you can strive towards a positive reimbursement increase for your facility. So lastly, I started with a quote. I'm going to end with a quote. Socrates, how valuable is he? He said, the secret of change is to focus all of your energy not on fighting the old, but building on the new. And that is still very true. If you keep focusing on everything that you did beforehand, you're never going to be able to build anything new. So, there you go.
We do have another question. Very nicely done, Erika. I'm going to put you on the spot with one last question.
Okay.
This is from Jeff, actually from our home state here in Minnesota, and I'm going to read it verbatim, and then I'm going to make an interpretation here. Jeff is asking, when you're looking to hire an IT consultant to help you generate and monitor KPIs, what should I be looking for to help me choose the right one? And I'm going to go a little bit broader than that. You know, when you're looking to enlist the outside resources of a revenue cycle management expert, what do they look for? I'm sure there's a lot of them out there, and so some are good, some are bad. It's like anything else. Insights for Jeff on vetting and selecting a resource?
The first thing I would say is you want to select a resource that is a absolute rock star at whatever software system you use today. So if you're a Meditech hospital or clinic or an Epic hospital or clinic, you really want to keep your focus within that pool of folks. So find a company that specializes in your software system, and then from there, you want to really maybe interview the person and ask them to maybe bring some samples of data that they've pulled for other facilities, or explain some of the key KPIs that they would run, and maybe get some of their insights and see how it aligns with what you're thinking. Because if they're going to start tracking your DNFB, days not final billed, or your net days in AR, when you really want to focus more on your ATB or your AR, you're kind of in two different spots. You're in two different areas. So you want to align yourself with a consultant, an IT expert that, again, knows the system and can understand and really translate those KPIs into something that is manageable and useful to you.
Good. That's great insight. I'm sure Jeff and others found that helpful, Erika. Thanks very much. In closing, I have something important to share with you. In the time that we've had together today, Erika has worked very hard to provide you with some advanced strategies and some best practices and some practical tools for leveraging revenue cycle management in your organization. As I mentioned at the beginning of the webinar, this webinar is being recorded, and it will be made available to you. You'll receive an email in a few days after we've had an opportunity to process the material, and it'll also be available on our website in a few days as well. And also, if the content of today's webinar resonated with you and the insights that Erika provided, hit home for you, and you'd like to explore this topic further, for your business and for your organization, you can reach me directly at the address here, kmcardle@sisusolutions.com, or that's my direct dial number as well. So if you'd like to go deeper on this, if you have further questions, if you'd like to explore this further, I'll get you connected up with Erika or the appropriate person here, and we'll support you however we can in your organization. So do know that the recording will be available, and we're available for further exploration as well. And then finally, I want to thank you and really acknowledging you for attending our webinar today. We had an amazing turnout. This is the most people we've ever had sit in on one of our webinar. Clearly, Erika, and this topic of revenue cycle management is resonating. It's a timely topic. So thanks very much for your interest in our program. I hope you liked what you heard and found it a tremendous value for you and your organization. And thank you again for joining us. Until next time, this is Kevin McCardle and Erika Running and the entire Sisu Solutions team just wishing you all the best.